Time now for this week's Health Matters. I'm Paul Critz, and PA Lynn Szabo in the house today, talking about, first off, before we get into this, you said when you walked in today that yesterday at the Saturday hours at the walk-in clinic, you saw 30 people?
I did.
That's a lot more than I've ever heard you say before.
26 was our previous, high. 26 was our previous high.
Okay.
So we smashed the record.
Okay, so then 26 would have been, that's like, what, flu season high, right? That's
right.
like a lot of what?
That's like sick kids high.
What'd you see yesterday?
I saw a lot of women's health.
Really?
I saw a lot of responsible young men coming in for STD checks.
Wow.
Kind of what we call peace of mind checks, because they're not really symptomatic. They're just doing the right thing. I saw a lot of elders with knee problems for some reason, and follow-ups for MVAs, that's motor vehicle accidents.
Oh, wow.
And, a little bit of this and a little bit of that. Still a lot of upper respiratory infections. There was a bad non-identified virus that came through town, I think, about a month ago, and so clean up after that.
No, you don't have to tell me, because I think I enjoyed the company of that unidentified virus too. So, well, yeah. I'm glad you had an engaging day.
It was, but I'm like kind of exhausted.
Yeah,
but it was super fun. It's the nurses that I work with, really high quality healthcare providers in their own right, are we really felt like we did something. So that was cool.
That's good. That kind of end of the day esprit de corps.
Yeah,
like
when
that.
we're all like, what just happened?
Right on. Okay, so for this week's topic, and again, just as an aside before we get going, I was talking with my wife right before you showed up this morning, and she asked what Health Matters this week was going to be about, and I told her, and I expressed some sort of doubt. I don't know how we fill a half an hour on this,
Right.
and she went, only a half an hour?
Oh, it's a fascinating topic.
Okay.
It's lab work. Labs 101.
See, at lab work, I'm like, yeah, whatever.
Yeah, that's
but
good.
no, my wife is also one of those patients who's like on my chart and checking to make sure. And she's
Right.
oftentimes she'll come back with questions about her lab work that, the person on the phone wasn't prepared to answer. Because
Right.
they're like, oh,
Absolutely.
okay. All right.
Yeah.
Lab work. Well,
Yeah. So kind of patients ask about labs constantly, and they'll even ask about labs that they had drawn like a year ago.
Oh, wow.
So it's on their mind. They want to have some understanding of that frame of that brief snapshot of their biochemistry. So, and then, first of all, you should probably know that there's millions of lab tests.
right.
There's blood, there's cerebral spinal fluid, there's cultures, there's, all kinds of stuff. And if you put x-rays in there, it would really get wild. But, and the other thing to really understand is the labs that you had done 6 months ago may not be relevant to your current clinical situation. So that surprises people.
Really?
So if I'm trying to diagnose somebody, say with a pneumonia, and I'm trying to decide whether it's a viral pneumonia or a bacterial pneumonia, they'll say, I had blood tests 6 months ago, and they're really hoping that it's helpful.
Yeah.
And
that's nice for you.
No, it's not. We're looking at a more current problem in real time.
Right.
So, but I kind of made an outline on the 3 basic labs that most people order all the time, like maybe 100 times in a day, actually, because they give the most information as a jumping off point.
Okay.
Okay. Especially if they don't look right.
And so,
And sometimes if they do look right.
do we need to set the table as far as the kind of labs that you'll experience or that will be done to you, just based on your visit? Like if you're just going in for a checkup, I imagine there's a whole panel of labs that get applied in that situation as opposed to coming in with a specific problem, right?
Right. You'd be surprised that they're actually kind of the same.
Okay.
So there's what you're saying is there's screening labs.
Okay.
For example, cholesterol, and we're going to talk about the lipid panel later on, but also, things that address a more acute problem,
Right.
like the pneumonia just mentioned, but also things that are kind of relevant in the in-between time. So what we call the subacute, not quite chronic, which is greater than 6 months or 6 weeks, and not quite acute, which is, I would say, about 3 weeks or less.
Okay.
So kind of a subacute, so hanging on kind of problems. Yeah. So if they're normal, that can be reassuring. But also, if they're normal, that might be a point in a decision-making process that turns the provider's attention to something else. So normal doesn't always mean 100% good.
Right.
It's kind of like a dichotomous key. Should I define those?
I think I get what a dichotomous key would be, but go ahead and define it.
So that's where science goes. If it's not this, then it's this.
Okay.
Okay.
Sure.
So it's a fork in the trail. Does that make sense?
Yeah.
So the first one is the CBC, which stands for complete blood count. This is probably the most ordered, I would guess, and the most important lab test that it's certainly the one we're taught first about in school. And just as a somewhat of an aside, when you're in school, you have to memorize all the normals. So that's like 100 normal ranges.
Oh, wow.
Yeah, there's a lot of tests in this little CBC. But it tells us a lot of things. So I just mentioned that it can tell if somebody has a bacterial or a viral infection. I would add on that. It could also kind of suggest if somebody's symptoms, maybe sinus congestion or something, are more tied to allergies or parasites, which is kind of gross. But so you can get a lot of information about it. It can also tell us if somebody is anemic. And anemic is not low iron only. There's a lot of different kinds of anemia. There's about 5 different kinds.
Really?
So it can give suggestions about whether it's more of a low iron kind of anemia or whether it's a vitamin B12 deficiency kind of anemia, or other different vitamin deficiencies, or whether it's a genetic state.
Oh, okay. Yeah.
Okay. So super important. One thing it doesn't really help with, and this surprised me when I was in school, but acute blood loss, chronic blood loss it'll address, but not acute blood loss. So acute blood loss is best addressed with vital signs. So it can also tell if there's too many red blood cells. So maybe you don't have enough, but maybe you have too many. And sometimes I'll look at something and just make a comment like, "Are you a smoker?" And people will be astounded.
Oh, wow.
Because that's one of the things that makes people have too many red blood cells.
I'll be damned.
Yeah. And then also another disease common in middle-aged men, polycythemia vera. So I just picked at what I think is a case of that with somebody just this week. So we're only talking about a CBC. And I would say within that, there's probably 9 real data points. Okay. That kind of in combination or in just by themselves can suggest the course of somebody's illness.
Wow. Okay.
Yeah.
Okay.
Kind of helpful. You can also tell if somebody, it looks at platelets, and you can look if somebody doesn't have enough platelets to clot blood. So I once had a case where a man came in and he was peeing blood, and usually the first thing I think the average provider would think is, infection or kidney stones. He actually had a virus and his platelets were under attack.
Oh, wow.
So he was hospitalized because he didn't have anywhere near enough blood clotting ability.
Oh, my God.
So that came just from a CBC. So, and like I said, you can look at vitamin deficiencies, alcohol abuse, or leukemias. So that's a lot for 9 data points, I think. A lot of different diseases. And plus, remember, I already kind of suggested this, you don't always look at one point in time. You look at the gestalt over time, how things change. So you can see if maybe a postpartum woman is, bouncing back from, a birth bleed, something like that. So super important blood tests. Probably the most common thing that an individual will have done on them in their lifetime. So the next one is it's a CMP. So we talk in acronyms in medicine. This used to be called a SMAC. I thought it was funner when it was a SMAC.
Yeah, CMP's boring.
SMAC. So, but anyway, it's a comprehensive metabolic profile. Okay. And it probably has about 15 data points. Okay.
All right.
So I should, as an aside here, say that a lot of a lot of lab tests are collected in panels. Okay, so like a CBC has 9 data points. You could order any one of those data points individually, but the capitalism part of medicine has created machines that mean you have to go for all of them.
Oh, wow.
So you can't go for like 3 of them if you're just monitoring one value, a single value or something over time. So I think that probably makes these tests cheaper because they're all done on the same machine.
It's like standardized and efficient.
Right.
Yeah.
And so if I ordered just one,
that would
probably
be non-standard.
the whole thing would probably be actually done, but the only reported one would be the one I ordered.
Right.
So even though the CMP or comprehensive metabolic profile has a lot of data points in it, it's really hard to, if you're only looking at one thing, it's more expensive and more difficult to look at that single thing. And so oftentimes, and it's got the cool acronym. So you just go.
Yeah, sure.
Yeah.
And I imagine, this depends on each situation, I'd imagine, but there's an interplay between those data points too that you need to sort of see as well, right? Yeah,
totally. Sometimes and totally not. Sometimes.
Yeah. Depending.
Sometimes I'm only looking at one data point, okay, or a couple.
Mm-hmm.
So comprehensive metabolic profile talks about liver function, and those tests are specifically what we call AST or ALT. Those are liver enzymes and alkaline phosphatase. Okay. So the liver enzymes are super specific to the liver, the AST and ALT. Those are transaminases. I can't really give you the complete name because I don't think like that anymore. I just studied that for the test.
Yeah, it's just the acronym, like from then on all the way. Okay.
But alkaline phosphatase is kind of an interesting test because sometimes it tells you about the liver and sometimes it tells you about other organs in the body. And sometimes, most specifically, it's helpful in looking at bone health.
Okay.
Does somebody have a problem with the way their bones are growing? Now, bones grow all the time, even in people our age, and they constantly break down and constantly build up. And so this is something that kind of looks at that process, but not directly. It's kind of a gestalt. There's an art. The art's coming in here. But AST and ALT, oftentimes people will have elevated liver function tests because they got a little bit of Hep C that hasn't been treated yet, or they drink a bit, or the most common thing here is fatty liver.
Oh, sure.
So
Okay.
people are just overweight, and there's fat deposits in the liver that cause the liver function to be elevated. And so this is kind of interesting and a worthy aside. People get excited if the normal is, 12 to 35 for one of these, and somebody's 36. What that says to the patient is terrible disease. I'm not normal.
I'm over the line.
This is scary. Oh my God, do something. But for some of these tests, we don't really get excited until you get to 10 times the upper limit of normal.
Wow.
And liver function tests are, so 32 is probably 35 is like a reasonable normal for these liver function tests. So we don't get excited until they're like 350.
Oh my God. Okay.
I mean, we'll scold somebody if
Don't drink
they're
so
going
much,
up,
but yeah. Less pate.
But the provider doesn't even look at that as super abnormal. If the upper limit of normal is 35 and they're 36, it's kind of like when you get pulled over coming down off, by Crescent Beach, and what's the speed limit there? 50,
Coming down off the hill?
Yeah, 55. 55. Yeah. And so if you're going 56, it's unlikely you're going to get in trouble.
Gotcha. Okay.
They're looking for the people that are way faster. Okay, and the next thing that this comprehensive metabolic profile talks about is kidney function. And this is actually kind of interesting because there's some political controversy in here.
Really?
Yeah.
Having to do with the
racial differences.
Oh, okay.
And the GFR. So that's it's a little hard to say, glomerular filtration rate.
Wow. Okay.
Okay. And so kidney function looks mostly at creatinine. Where our eyes go first on the paper is creatinine, which is a marker for how efficiently kidneys are filtering, because that's their main job. And then the GFR is a marker not only for the efficiency of the kidneys, but kind of in real time what's happening.
Okay.
So you can have the same creatinine, but a really different GFR.
Okay.
if there's been some kind of kidney insult. So people of African descent, what's normal for them is different than what's normal for Caucasian people.
Okay.
And probably Hispanic and Hmong.
And so what? I just imagine that those variances haven't been addressed historically, right?
Right. They haven't. They all of a sudden showed up on the reporting mechanism recently, and I thought, great, they're finally looking at, there's differences, and we have to take this in consideration. But actually, I read recently that that some people in the communities of color don't like that because they think that keeps them, because they have different normals or slightly lower, that keeps them from being able to access dialysis.
Oh, wow. Okay.
So they see it as a block to healthcare services that they need. And so that needs to be hammered out by greater minds than us.
What needs to change in that situation then? Is it just a matter about, teaching the population that this difference exists for a reason?
I think part of it is teaching the population about science, and part of it is hearing what the population has to say about their access to care.
Gotcha. Okay.
Yeah, and then I'm sure there's more refined ways to look at it, and I bet they're right now, even as we speak, researching a better test.
Okay. Yeah.
So that's the real answer, in my opinion. So I can also tell about people's electrolytes like sodium, potassium, chloride, and calcium. And these are important. Let's say if somebody's on certain medications, somebody with heart failure might be on diuretics or medicine that makes them pee, and then they pee out too much potassium, and they need potassium supplements. There's kind of also an art here in some of these electrolytes. If you look at the relative values, they could all be normal, but if you're looking at the relative values, then you might be looking at a metabolic problem. So there's a subtle art here too.
Well, I mean, does this have something to do with? I mean, it's not listed here. I don't know where it falls in as far as electrolytes goes, but I'm thinking about like magnesium.
Right, that's not on this profile, but I bet you it's going to show up because magnesium is the darling of the hospitalists right now.
And you can't have magnesium working the way it's supposed to work without the right amount of calcium too, right? So you have to know
you have to order magnesium separately, and it kind of is right now getting lost in the shuffle, I think. So I think it's going to show up on these. I think the comprehensive metabolic profile will become more comprehensive. Okay. So that's important for monitoring medication, for monitoring diet, for monitoring if somebody's dehydrated, et cetera, et cetera. We can also tell about people's nutrition, and that's the albumin. And that looks a little bit at nutrition, but also as part of the Gestalt, looking at how the liver's functioning, and might be important in certain kinds of cancers like melanoma. I'm forgetting it, but certain kind of cancers will show up first with albumin disorders.
Wow. Okay.
Okay. So people are always surprised when I look at something and I say, "Are you eating okay?" And they'll be like, "How'd you know that?" And then getting back to the metabolic status, there's also the measures carbon dioxide and measures anion gap, and that goes back to the relative proportions of the electrolytes, and that can tell you if somebody's having a problem because of their meds, or if they're having another problem that makes one of their meds dangerous, or what their metabolic life is like. And at that point, it's on the hospitalist level and the intensivist level, and they're really looking at subtleties, and the art of medicine comes in super clearly.
Wow. Okay.
Not the family practice.
Okay.
So, and these, you have to remember, these are starting points, and, things change over time, and the change becomes important too. Okay. So the other one too, this is more for long-term healthcare maintenance, a lipid profile. This is what people are talking about when they want to know if their cholesterol was checked. So we used to just look at cholesterol. Over 200, shame the patient about their diet. Under 200, just sign off and don't think about it further.
Okay.
Okay. Although weirdly, the sickest people I saw in the Castro with HIV disease had really, really great cholesterol.
Really? Huh.
Yeah, because they were malnourished. But anyway.
Oh, because they were okay. So
Yeah. So we're never happy, is what I'm saying, as far as providers. But this profile looks at triglycerides, which are kind of interesting molecules. They are what, when they come together in certain arrangements, become a glucose molecule.
Okay.
Does that make sense? Okay, I think of them as pop beads. You remember those? Our moms probably had them.
Pop beads.
Pop beads. So it looks like a pearl necklace, but you can take it apart and it's actually plastic, like circular things that are all connected to each other.
Oh, wow.
Okay, these are the individual units.
Gotcha.
Okay.
No, I have no idea what a pop bead was, but okay.
Really? I keep forgetting you're not as old as I am. Okay, and then so triglycerides are important in people who are kind of leaning toward diabetes. Their triglycerides will go up. So also it looks at good cholesterol, which is HDL, and bad cholesterol, which is LDL. Okay.
Yeah.
So when people want to know about their cholesterol, they really want to know about their bad cholesterol.
Right.
That's really what they're asking. What's my heart health? But you can't take any one of these numbers and come up with a conclusion.
They all have to be taken together, right?
They do. So in which case, this is kind of a new thing for providers. We have apps on our phone that have kind of biochemical calculators.
Okay.
And there's a special one from the American Heart Association. It also kind of mimics the American Cardiology Association. So, and we plug these numbers in plus gender, plus age, plus past medical history, like are they diabetic? Are they on antihypertensive meds?
Wow.
And we can figure out somebody's 10-year rate for having a stroke or a heart attack.
I'll be damned.
So that's the important number.
That's interesting. Wow. Okay.
And-
Okay. So
and
what's
I've only started doing it in the last 2 years, so
what's
this
the
is new.
what's the important number you're looking for again?
It's the rate, it's the percent chance that in the next 10 years that this individual is going to have a heart attack or a stroke.
Wow. Okay. So you can take the triglycerides. You can take what else do you got other factors then
You
about
plug it all in, plus their meds, their gender, their age.
and it does the
their
algebra.
ethnicity.
Okay.
Okay.
Wow.
And so sometimes I see people have a 0.2% percent in the next 10 years of having a catastrophic cardiac or CVA, which is cerebral vascular accident. Or I've seen people up to 50%.
Whoa.
And this is my favorite thing to show people, because I whip out my calculator, I put the numbers in actually while I'm in the room with them, although I did it ahead of time, so I kind of know where we're going.
Yeah.
And I can, get somebody with a lot of risk factors to, a number of 50% is super scary.
Yeah.
So that means in the next 10 years, you're a coin toss.
Just as likely. Yeah, that's it. But I just love the fact that you've got all these different factors that interact with each other in like a nonlinear sort of fashion, and you can put them in an app.
Right.
Did you get that in the App Store, or is that where do you get a specialized app like that?
Oh yeah, there's an app store.
Is there?
There's a medical app store.
Okay.
Are you
Okay.
kidding?
Cool.
It's totally. But
Well, yeah, no, I know, but it's just not something I can just go download apps from it,
so
right?
my app, if you want to talk about my app, I have a medical library app, and it's called Hippocrates.
Hippocrates.
That's
That's good.
It is not probably the best one, but it's the one that I've grown used to. So and I whip my phone out. I carry my phone into the exam room. I ignore it for all other things until I need to, quote unquote, step into the medical library, and I whip it out, and patients find it interesting. And I can say, really? 36%? If you just change this and this, because you can also do that. It's flexible enough in the app. So let's say somebody's a smoker and we change to non-smoker. Well, you go from 36% to 9%.
Wow.
Dude, you have to do this. This is super cool.
That's a really interesting tool. That's cool.
Yeah, it's a super interesting tool. So, so if your provider can't give you this number, then you should ask them to.
Okay.
Okay.
Specifically asking for the percentage
of
the probability that you'll have
heart
some
attack
of
or stroke in the next 10 years. So you could just say, can I have my AHA
Okay.
risk factors.
AHA. Okay.
And if they don't know what that is,
yeah, go to a different doctor.
that worries me.
Yeah.
Come see me on Saturday.
Yeah.
Okay.
Okay. Good to know. Wow.
So here's the next thing. So we've talked about the three categories of labs that are the most common, and I've mentioned that there's hundreds of other ways to look at stuff. And there's also, they come in panels and they come in individual tests, and there's the art of medicine comes in, and your provider needs to be up on all this stuff. Mm-hmm. But what I hear constantly is, how come I never hear back with my results? Mm-hmm. And this super annoys patients. And I kind of understand when I'm in my patient modality that, I kind of get that. But I think there should be an understanding that we have hundreds of normal tests that we go through a day. Mm-hmm. We don't even truly look at them sometimes. It's either highlighted in bold or it's not.
And if there's no reason to see it because there's
sign off, put in the scan basket.
So if you don't hear anything, is it a good thing?
No.
Okay.
I don't think so.
Yeah.
So for most of the time, what I tell patients is there's no way we can call you all back with normal lab results. And that call also is opening the door to an extension of the visit, mm-hmm. which, remember, we're working under a capitalist system here. We've talked about that. That the provider doesn't get paid for. Oftentimes they're staying late at night. Oftentimes they have obligations that they have to get to that are outside their practice. Mm-hmm. So I don't mean to sound like they're selfish with their time. But
they're people.
But yeah, they've got lives and they work super hard and they don't get paid for as much as you'd think. Mm-hmm. So there's just no time to call everybody with normal results. But results that change the plan should be called back and acted on.
Right.
So that's what I tell my patients. It looks like you got a viral syndrome right now. I'm getting the CBC. If it looks like it's really bacterial and I'm missing something, that result would change the plan, because then I'd put you on antibiotics, mm-hmm. right? And so then I'm gonna commit to calling you back, or you might end up talking to the nurse, but action will happen, mm-hmm. which is what the patient wants.
Yeah.
So it is always okay. You can assume that, I think you're pretty safe in assuming everything was normal, but it is always okay to call. And if you don't hear in a couple of days and you're concerned, call. And in my practice, call Nurse Aaron, because he's the guy who has the answer for everything.
Nurse Aaron's the person to talk to.
Yeah, he's the man in the know, and you can specifically ask for him. But he's at UHS. If you're talking about open door, I would say call Nurse Sarah or Nurse Amanda, because those women are on it and they want to be able to reach out and get your questions answered.
And again, this is something you've revisited time and again.
Right.
In Health Matters, is you need to be your own advocate. If you have questions,
super true.
If there's a void needs to be filled in your knowledge, then yeah, you should call and fill that void.
You should get a call back, and if you don't, then work your way up the power chain and find out why. I also think it's reasonable to ask a patient to return to clinic to discuss results, mm-hmm. especially if the result is unexpected, or maybe the result is normal, and that's going to trigger a direction on the path that's different mm-hmm. than was originally talked about in the room. Is that clear?
Mm-hmm,
what
mm-hmm.
I'm saying? So anything that changes the plan, and a normal result might change the plan.
Right.
Okay. So
I like this next point you have. Get a copy of the labs and keep them in a folder.
So this is what I do in my practice, especially I think it's known that I work with pregnant women in the Native community, and I hand them copies of their ultrasounds, their lab work, their mm-hmm. screening stuff, their diagnostic stuff, and I say, put it with your go bag. Mm-hmm. And when you get to the hospital, we have sent records multiple times, but electronics are imperfect and you are not. So, that will help you get the care that you need while you're in labor. And I would say the same thing for anybody. So when I call people in, or when I'm just seeing people routinely, my MAs print up hard copy of all the lab work that was relevant from the last visit. Mm-hmm. And sometimes they'll go back quite a ways. and I'll hand it. And 99% of the patients, first of all, you can discuss it uninterrupted in context in the exam room, and they really like that.
Yeah.
They like looking at the numbers. They like thinking that represents them, and it seems it's very rare that somebody will say, I don't need that. You can just shred it."
Do you think so? My chart, things like that. Is that's not a substitute for that kind of hard copy record keeping?
Well, I don't know if it would be the best way to do it if somebody was in labor and presenting the setter.
Yeah, good point. What's your login? Yeah,
Yeah,
good
that's
point.
right.
Yeah, okay.
There's no bandwidth. I don't know.
Yeah,
something happens, you drop your phone. Anyway,
sure.
it's just easier to have it all in a folder. And I would say the same thing about an elder, and you could add also the advanced directive in that. So living wills.
Okay.
Just have it. I think it's important. I love looking at my own personal labs.
Really?
Yeah. It's fascinating. It's like watching one of the most fascinating movies you'll ever see.
Look back in time in your labs. Oh, I was so young then. Look at these numbers.
Yeah, I know. My liver was happier. Actually, with me, it's my kidneys, but it's a reminder to drink more water. Anyway, keep in mind that it takes providers years to learn how to interpret labs. And I remember when we had our first, lab lecture when I was in school, and they said, okay, well, on the test, you're going to be expected to know these normal ranges. Number one, normal ranges change a little bit depending on the reporting entity of the labs. Number two, that's like 200 data points. And so there was immediate whining. But as you look at them again and again and again, you tend to just kind of memorize them anyway. And so sometimes I can look at a piece of paper with a glance and have all the information I need, and patients are surprised by that.
Right.
And most providers, we can pick it up.
Well, yeah,
fast.
sure.
Yeah. So there also is no substitute for the subtleties. Okay, for understanding the subtleties. So if you're on my chart and your sodium is a couple points high, or here's one that's common: your liver function test is a couple points high, and that says to you as the patient maybe doesn't know much about medicine, oh my God, I'm going into liver failure.
Right.
You can't Google, you can't do Dr. Google and get a better understanding of that. You should talk to your provider. Yeah. So keep in mind, I think of this as the film of your life. We've talked about that. There's only one frame in the whole story, and lots depends more on the gestalt and how things change over time.
Right.
Yeah.
Wow.
So.
Okay, well, yeah, that did.
Yeah.
That filled up more than a half an hour of...
Really? I can talk forever about medicine, apparently. So.
No, that's wonderful. Well, thank you very much. That's great. And my wife was right. Yeah, and she's always checking her levels, and she's noticed levels in her my chart and gone back and brought them up to someone's attention, and they've gone, oh, well, yeah, good point.
Yeah, right.
So yeah,
you have to advocate for yourself. Clearly.
Yeah, exactly. Yeah. All right. Lynn, Szabo, thank you so very much for this week's Health Matters. Any idea about next week?
No, actually.
Okay.
I'm open to suggestions. You got any?
Oh, let me think about that, because I may, yes.
Okay.
I'm older enough now, I'm thinking about health all the time.
Okay. All right. Okay.
I have a sore foot, actually.
Yeah, osteoarthritis might be a good topic. Their arthritis, joint pain.
My plantar fascia, I think, is what it's doing.
Oh,
yeah. I've been walking hard. Oh. All right. Well, thank you very much, Lynn Szabo, PA Health Matters. We will talk again next week.
Okay. Thanks.